Well, good evening or good afternoon, wherever you are. Here it's Patty DeGangi here, sitting at my own desk with a computer that's not plugged in, with a cell phone at my side that's not plugged in, reaching out to people all over the country and all over the world. Now, that's the world we live in, that cordless world, no strings attached. Now, some of you watching here may not even know what that is. See, when it comes to polishing, tooth polishing, we actually started out cordless. How cordless? Well, that little unit there is called a port polisher. And it used an orange wood stick, and it went in a handle, and that's how we used to polish teeth. So in some ways, we come full circle with going from cordless way back in the beginning to cordless again today. In our short time that we're together, I'm going to look at reviewing some of the changes that we've had from port polishing all the way to today's options. Talk about the difference between selective polishing and essential selective polishing. We know we have many state practice acts that are changing, and hygienists certainly are usually the people that are primarily responsible for polishing in dental offices. Yet also there are others, including dental assistants, that can do it. And understanding these concepts of selecting and essential selective polishing are very important. And that's where we're going to talk about some of the options. What are our choices? I thank Dentalese for their educational grant to do this program, as well as Leviva Learning for allowing me to do this. So here's a question. Should we polish every patient? It certainly is common. It's certainly what we have taught people to expect. Let me talk about that for a second. I've been in dentistry for some time, and the idea that people call to get their teeth cleaned, which for many people equals polishing, was not the way it always was. People have been asking that for years. Well, actually, we taught them to ask for that. When they call a practice, what are they really calling for? Are they calling to get their teeth polished, or are they calling really for our professional expertise? And again, we've taught them to polish, that polishing is what they need. Should we polish every patient? Well, that question has been answered, like 20 years ago, 40 years ago, it was a different answer than it is today. Which brings us to the world of Dr. Esther Wilkins. Well, that certainly is a name that's familiar to any hygienist, and probably almost anybody in dentistry. Dr. Wilkins has written the definitive guides for books. I think any hygienist in any part of their education has probably bought a copy of Dr. Wilkins' book. Well, in her fourth edition back in 1976, she talked about the concept of selective polishing. And it was reviewed in an article by dear friend Karen Barnes in an issue of Dimensions of Dental Hygiene. And what Dr. Wilkins said about selective polishing is a selective procedure, and not every patient needs to have their teeth polished, especially on a routine basis. What that led to is the idea of teaching selective polishing in dental hygiene schools. And the concept came from the 70s. Dr. Wilkins talked about it. It was supported by the American Dental Hygienists Association in a position paper in 1995. The whole idea of it was about treatment options. One size doesn't fit all. The polishing should follow what's best for that patient. Well, I've gone across the country and asked audience after audience, first of all, how many of them were taught selective polishing in school, and how many of them actually practice it? The reality is not very many. I found this little funny on the internet, and selective polishing was like 49 other ideas that actually never took off. Yeah, pigeon-guided missiles, how'd that do? Probably about as well as selective polishing. Why? Because it became such a routine, again, that we taught our patients, and the expectation was there, and we lived, as practitioners, we lived up to that expectation. So there was an update in 2012 in Dr. Wilkins' 11th edition of the book, and again is highlighted by Karen in her article, came up with the concept of essential selective polishing. So what's that? Well, that dental hygienists and those others that are responsible for the duty of polishing can feel free to polish all teeth, whether they're stained or unstained, as selective polishing has been redefined as essential. But let's look at that a little closer. What does that really mean? Essential selective polishing is about selecting the right agents and the modalities according to the individual patient needs and risk. Risk. That's something I talk a lot about in my courses on every level. Every kind of course I have, I'm always talking about risk and risk assessment. Why? Because it makes so much sense for the way we can and should be treating people. It's not just about finding the damage after it's done. It's about identifying someone's risk and doing the best we can to allay or reduce that risk. Risk should really be the basis of our choices. It's not just, again, what someone has, but what they're at risk to have. You see a little band of DNA that I have there. I have that there to talk about risk. See, in my family, my own family history, my own history, we know I carry a risk for colon cancer because I have a father and several of his siblings that have already had colon cancer. So we knew that we had that risk in our family. Yet, what changed is that my father had genetic testing done for a link to colon cancer, and we found that we have a genetic link for it. Now, I had my baseline colonoscopies as recommended by associations, yet I have a 26-year-old son. Should we wait and use those same guidelines for him? I think the answer is pretty clear that no, that doesn't really make sense. We know that we have what we call a non-modifiable risk factor. In other words, we can't change that genetic propensity, but what we can do is change our behavior because we know that that person has risk. People take blood pressure medications. Why do they take blood pressure medication? Because we know elevated blood pressure puts that person at risk for stroke or heart attack. And the medication is to help reduce the risk. Risk-based care, risk-based thinking. Because risk is what really should determine how often we take radiographic images, what someone's recall is, how aggressively we should treatment plan. And key to what we're talking about here in this webinar is the materials that we use. It also has something to do, and a great deal to do, with how we code. Whether we realize it or not, insurance companies are all about risk. Their whole business is based on risk. So the more we start using and start thinking risk-based thinking and risk assessment, the better off we can serve our patients. The entire philosophy of caries management by risk assessment, or CAMBRA, Cariology philosophy, is based on, again, caries management by risk assessment. So how would we use risk assessment in essential selective polishing? All of these are recognized risk assessment tools. Again, as well as our health histories. There's paper forms, there's all kinds of electronic technologies. Matter of fact, ones that are cordless, as I will show you, that we can do to gather the risk to make the right choice in this whole arena of polishing. One is an interview-based risk assessment form. Now, these are paper forms, but of course everything is electronic, so they're all electronic. The one on the upper left is the American Dental Association's version of a risk assessment form, and the one in the middle is from the CAMBRA people out in the West Coast that got the whole CAMBRA movement going, as well as the Carie Free Company provides these paper risk assessment. What's important to understand with each of these is it talks about, yes, what puts someone at risk as far as breakdown, but it also has information on what helps protect the person's mouth. From that, we get a quantifiable score and category that we put them in, that they're in low, they're in moderate, or they're in high risk. If someone is in a high risk category, what these forms also help identify is what puts them at risk. Because polishing with just anything, using anything on someone at risk might not be the most appropriate choice. Then there's the tools like the Diagnodent, or one of my favorites, the Spectra. These are designed not to find holes to fix, but they're to assess the surface of the tooth structure. What this particular one, you can see the name, they call it a Doppler radar because it works by sounds, and it will tell you if there's sound enamel, if there's some beginning breakdown, if you get some deep, and you can see the color spectrum there. It helps us to identify. Now, what we use to polish these surfaces can make really a big difference. Are we doing something that's more harmful to them, less harmful to them? What is the state of the health of that enamel in the first place? How about a disclosing gel? Again, well, aren't we polishing to get this debris off? Well, yes and no. I think we need to look at this differently than we once did. At one time, our whole goal was, oh, well, we got to get that off. We got to get that. Look at the colors. Look how harmful it is. But let's look at this a little further. This particular disclosing gel tells you three things. Pink is new plaque. Blue is old plaque. But the last one, the aqua, that's one that's really important to understand, and the risk inherent in it. And when it turns aqua, that means there is a pH that's less than 4.5. Now, when we're talking about an acidic environment in the mouth and a pH that low, the selection of both the polishing compound and the way that we polish is really important, because that's a very, very high risk situation. This is also a chairside test that we can perform that gives us some idea of risk. When we're talking about, saliva is really the most important tool that we have, that we don't use, to be very honest. We don't use it very much. But what is the state of that saliva? How healthy is it? Because based on all of these different measures, we're finding out the risk, the breakdown. Are we in a state of breakdown? Are we in a state of healing? Where are we? All of them to quantify risk. All of them that put somebody into a low, moderate, or high, in which we do primary, secondary, or tertiary prevention. What's primary prevention? What's secondary? What's tertiary? Some people need all of them. It's different levels to help reduce the risk and help the body heal itself. So, general categories of polishing agents come. The ones that we know most commonly are the polishing compounds with abrasives. Usually come in grits of fine, medium, coarse, and extra coarse. And it saddens me to say that the number one selling of those are the coarse and extra coarse. I highly question the need for using coarse or extra coarse, almost ever. I'm much more in favor of a fine, maybe a medium. But when I talk about stain and stain removal in a minute, you'll understand what I'm talking about. There are other polishing agents that are cleaning agents. In other words, they clean and you can polish the tooth structure without having the abrasives. There's also the pastes that are for aesthetics. As a typical baby boomer myself, I have 11 crowns. I have 6 porcelain veneers. I think it's really important that we use the right compound, again, delivered with the right modality when we're talking about these advanced prosthetics that people have invested a great deal of money in and we don't want to damage. Then there's the air polishing that's been around for a while, and there's been some resurgence to using air polishing subgingivally. That's another course that we can do at a different time. But the category I really am interested in talking about is the smart polish. What the heck is a smart polish? Well, it's about finding the right fit for the right size. And I happen to really like the smart polishes. But it's still, even within that category, we have a lot of options. As this picture so clearly shows, one size does not fit all in any way, shape, or form. And here's a question for you to think about. Is stain harmful? In the arena of polishing, often we talk about the stain removal. Now, the reality of it is, stain in and of itself, is it harmful or not? And I'm going to submit to you, it's not. It's not necessarily pathogenic. The massive debris that we see on the teeth, as I showed just earlier with the person that was disclosed, is that what's harmful? What is the harmful nature? What are we really doing when we are doing a prophylaxis or when we are polishing? In my opinion, using polishing agent or polishing angle, whatever we're probably to remove this type of stain would be inappropriate. It would be much better removed with an ultrasonic scaler. Polishing is still important. It has a place, but not a place for this. Because often what's used is very abrasive and a very high speed in polishing to remove the stain, which could potentially harm the teeth. So what is harmful? Is it the stain or is it how we're removing the stain? That's why when it comes to polishing, what's the right fit? What's the best fit for that patient at the time that we're seeing them? It's not something we can decide prior to them coming in. Even if you saw them 6 months ago or 3 months ago, what is their current state of health? What is their current state of risk? What is their current salivary makeup? What is their current level of saliva? All of those things are factors that can produce and add to someone's risk profile. So, essential selective polishing using smart products, again, using according to that individual's need and risk is what we're seeking here. Now, smart polishes, different categories of them. What makes them smart is ingredients in addition to the standard ingredients or instead of. For example, MI Paste has an ingredient called Recaldent, which is calcium phosphate, ACP, along with CCP, which helps bind and release that ACP to the tooth structure to help remineralize the tooth. The Colgate products, the Sensitive Pro Relief, that product has arginine, has another smart product. New Pro with Novamin has the Novamin. Enamel Pro has ACP. Remin Pro has some ACP type calcium and phosphate along with xylitol. And then Young Dental came out with a new compound. It's called Smart Select. And what that is it's two different grits together, so you're choosing the right grit for the right surface. Those are what I call smart polishes because they help us. They help the tooth structure as well as doing what we want polish to do as far as any removal and smoothing of the tooth surface. It's about freedom. It's about freedom to choose.
So thank you so much for taking the time to be part of this webinar today. My name is Robin Cox, and I'm an instructor at OHSU School of Dentistry in the Department of Periodontology, and I course direct periodontal instrumentation as well. Also, I own and manage the Dental Hygiene CE Institute to provide CE courses for local dental professionals, and I'm excited to be doing this today. Today we are going to talk about glycine subgingival air polishing and the power behind the powder. This is a treatment which I use and have had used on me, and also I train other clinicians to use it properly. So it's pretty exciting for me. The key concept that I'd like for us to take away today is that subgingival air polishing is a safe, effective, viable treatment option for biofilm management in our clinical practice. And research supports this highly effective treatment that reduces clinician time and delivers biofilm removal more safely than traditional treatment methods. And we'll review how that works as we go along. So let's start first by talking about air polishing in general. Air polishing has traditionally been an option to manage stain, and the air polishing system uses a slurry of water and polishing powder pressurized by air to deliver the effective means to remove the stain and biofilm from the enamel portions of the teeth. That's our traditional air polishing. The polishing powders are key to the air polishing effectiveness. They're used as the abrasive to remove the stain and the biofilm, and there are two common types of powders for air polishing, and a quick review of them will kind of give us a little bit of a reference point. So sodium bicarbonate is the most commonly used, and it has a relative particle size of 60 to 85 microns. Sodium bicarbonate is crystalline and angular in shape, and it has apparent jagged edges on it, as you can see in the 500 magnification picture. It does have a salty taste because it contains salt. The crystalline shape shows evidence of the jagged edges that in turn cause the degradation of hard and soft tissues during treatment. And so it's the characteristics of the sodium bicarbonate that make it unsuitable to use on root surfaces and restorative materials and tissue, but it's an extremely effective stain removal and biofilm removal for the coronal surfaces. The calcium carbonate is a polishing powder that was developed to help reduce the structural defects and to be more pleasant for patients. And you can see that in these images, the calcium carbonate is more spherical in shape, more rounded, and it does have an average size still of 60 to 70. It's crystalline, but it has the spherical shape, so it's softer on the edges. It is neutral and pleasant tasting, and it doesn't contain salt, so there's no sodium-free restrictions. And although the calcium carbonate can still exhibit damage to dentin and cementum, it is meant for use of intact enamel only, and it's slightly less abrasive than sodium bicarbonate, but still meant for just the coronal surface. So many advances have been made in air polishing systems since the original ProfiJet or what have you, the big tabletop units. The cumbersome tabletop units have now been replaced with ergonomic, clinician-friendly handpieces that attach directly to the dental unit, which is wonderful. And many clinicians have forgone the use of air polishing strictly because of the setup and the maintenance was so involved with the older tabletop units. And with these new advancements, both to the equipment and to the powders, which we're going to delve right into, air polishing is really making a resurgence into clinical use. So for our discussion of the subgingival air polishing, the powder that we are talking about and that is widely used is glycine. Now, glycine is an amino acid. It's the simplest and smallest of them. It is colorless and sweet tasting. Glycine is a non-essential amino acid, and it is synthesized in our own body and is essential for many of our own body functions. So it's readily absorbed by our body with no negative effects. Glycine is used in many things that we use daily, for example, substitute sweeteners, protein drinks, supplements, and buffering agents in antacids, analgesics, and also in antidepressants, so it's widely found. It's important to clarify, though, that the glycine is not a chemotherapeutic. Glycine is merely a safe means of the physical biofilm removal with the air polishing system. So it doesn't, at this time, there's no known chemotherapy properties to it. Trials for the subgingival use of glycine began in 2003 in Europe, and it's widely used now in Canada and in European countries. And based on clinical trials and safety analysis for the use in Europe, it has no limitation to the depth of pockets in which it can be used. And Canada's FDA equivalent has cleared it for the use in pocket depths up to 10 millimeters deep. And in the United States, it is cleared to be used in pockets up to 5 millimeters deep. So it's pretty significant. So the size of the powder particulate for glycine is 25 microns, which is significantly less than those of any of the other air polishers. You could compare it to the size of like baby powder particles, which range from 10 to 40 microns, and it's very fine. It has a similar feeling to baby powder as well. It has very little grit feeling, and the particles are softer on the edges, not quite so jagged and pointed, and it's not crystalline either. The size and the structure is what makes it safe for the tooth surface, the oral tissue, and the dental materials, and that makes it safe for subgingival use, and we'll go into that. So, oh, sorry about that. I was clicking on the wrong slide on my other computer. So there are many advantages to the use of subgingival air polishing. Research shows that it serves as a complete biofilm removal on the clinical crown and in shallow pockets near 100% removal of biofilm. As mentioned in the previous slide, it's safe on tooth structure, including the root surface, and on tissue structure. And it also can remove light to medium stain. Glycine air polishing is indicated for all aspects of periodontal treatment. It's able to remove biofilm in a matter of 5 seconds per site. It's an excellent choice for the use of maintaining healthy mouth or removing biofilm in all areas that are difficult to access, difficult to instrument, and it does not have the negative damaging effects of hand instrumenting. So in the most cherished treatment, though, that we're finding for the glycine air polishing is that of perio maintenance, implant maintenance, and peri-implantitis or implant mucositis treatments. It's safe and effective on the treatment of diseased teeth as well as healthy teeth, and it's widely used as the first step treatment for implantitis and mucositis, and it's shown to be very effective in reversing and halting the disease process of these implant-related diseases. So that's very exciting. But of course, in order to be comfortable implementing this kind of treatment, we need to know that it's safe and effective based on evidence. And I could spend a long time going over all the research that supports its use, but I will limit it to a few studies that demonstrate the safety and the benefits of the subgingival air polishing. So these studies that I'm going to review are very, very condensed, and there's a great bibliography, though, if you wanted to look up these studies and read them on your own. They're really good. So these first two studies highlight the efficacy of the biofilm removal on root surfaces. In the first set of pictures, Fleming noted that complete biofilm removal was achieved in all areas up to 2 millimeters apical to the gingival margin, and an average of 50% removal of the biofilm in pockets up to 6 millimeters deep. And this is significant because it's the same findings for biofilm reduction and removal when compared to hand scaling and ultrasonic. So it's achieving minimally the same in those pockets that are up to 6 millimeters deep. They also found that the calculus present on the root surface didn't affect the level of biofilm removal. So the air pressure is going to clean the biofilm around the calculus and irregularities of the tooth structure or anything that's present on the tooth, which is different than ultrasonic or hand scaling. In the second set, in the second group of pictures and study over here, Peter Silka measured colony forming units compared to hand scaling, and what he found was that the glycine air polishing group showed significantly less colony forming units from 3 to 5 millimeters consistently, and compared to the Curat group. And the interesting thing is that in each of these, all the glycine air polishing treatment was performed in only 5 seconds per site. So while the control groups were scaled until no visible plaque was left on the instrument, and they had no time limit, the time limit was 5 seconds per site with the glycine air polishing. So in both of these studies also, the patients preferred the glycine air polishing over the mechanical debridement and did not find it uncomfortable or unpleasant. Well, I hope that answers some of the questions that you may have been having over the time. And I, again, appreciate very much everybody checking in and taking time out of your life to listen to me share my excitement about subgingival air polishing. And I hope that you get an opportunity sometime soon to experience it with a patient yourself.